So today's session is not about the technical aspects of stroke intervention. What we want to know is what is being currently done in Pakistan, what is the available stroke data here, and how the societies can coordinate to make a difference in the stroke intervention in Pakistan. So we've got representatives from neuroradiology, from neurology, and we've got Pakistan Society of Interventional Cardiology here on this forum today. So without any further delay, so whichever cardiac centers are doing stroke intervention at present, they all will be presenting their data today and they'll be sharing their program details. So we're going to start off with THI Heart Institute, and I'm going to invite Dr. Adnan Amin. He's an interventional cardiologist to come and give his first presentation. And I would request everyone to kindly stay on time. We would prefer to leave at least 20-25 minutes at the end for inter-society discussion to see how we plan to move forward with it. Thank you.
Assalamu alaikum everyone, my dear colleagues. I am going to start with first thanking the organizers for giving me this opportunity to present something from THI Heart Institute. It is an honor being here, and without further ado, I'll start. Basically, I'll focus more on what we are doing as a stroke program at THI Heart Institute, and if time permits, I'll be going for a brief case review as well. So, we started to entertain acute stroke patients from 2020, and the first and foremost thing was to develop a stroke team and develop protocols and training of team members as well. So our stroke team consists of, obviously, the first point of contact is the emergency room. And being a cardiac hospital, you've all experienced the first thing that happens when a patient comes in is aspirin, clopidogrel, and heparin. So we have to make people unlearn a few things and then make them learn things. So it's a learning curve, obviously, for everyone. So ER doctors, staff, cardiology fellows, we don't have a neurology program, obviously, so it's the cardiology fellows that are taking care of the patients. Obviously, you need a full-time neurologist, as well as the radiologist and radiology technician have to be on board as well. And for stroke intervention, you need involvement of interventionists. We have dedicated cath lab people. We have 2 different scrub assistants, 2 different circulatory people for assisting in acute stroke patients. Obviously, after the stroke, you need rehab, physiotherapy, so that is also part of a stroke program, a successful stroke program. And nursing staff in step-down, CCU, general ward, etc. It's not only to take care of patients who have been admitted with stroke, but also to recognize a new stroke in an in-house patient, because you always have a possibility of an acute stroke within an admitted patient. And establishment of a stroke unit, so you should have a dedicated area where you can admit your stroke patients with trained personnel. The first and foremost thing is a communication when a stroke patient arrives. Like we have for STEMI, we have an overhead announcement system, and that announces the stroke code. The receptionist at the emergency counter clicks on a few buttons and the stroke code is announced automatically. There is a communication to the whole team via WhatsApp group, and that's the team that I mentioned previously. So we have rapid triage, initial assessment, management going on as per devised ER protocols, and we are thankful to RIC and Dr. Javed Saab for helping us in devising those protocols. So immediate CT brain, obviously, and communication is obviously part of the WhatsApp group, but specifically for the neurologist and radiologist to read the CT as soon as possible. If the patient is eligible for TPA, then the administration of TPA should be started in the radiology department by the ER staff who has taken the patient to the CT while the CTA is being performed. When you do the CT, you rule out a bleed, you have a sign that this is an acute ischemic stroke, and if the patient is eligible, then you can start the TPA as well. Meanwhile, the preparation of the cath lab team is taking place. We have a dedicated lab for that, which is used for coronaries, obviously, but whenever the stroke code is announced, we try to move the patient or finish the patient or move the patient to the other lab if possible. And the information is also disseminated to the interventionists. So family counseling, initially, obviously, the neurologist is the one who's going to see the patient first before the interventionist. First, the neurologist has to do the counseling. And obviously, while the patient is being prepared, the interventionists have to do the counseling. So that's what happens, the neurologist and the interventionist, because you have to realize it's not like a coronary case. You might not have a very good or successful outcome as per the patient's family's views, because they're spending money and they see the patient is still hemiplegic after 48 hours, after 3 weeks, after 6 months. So that has to be communicated to the family very precisely and clearly. We have also, because we don't have a neurosurgery setup, so we have an MOU with another local hospital and neurosurgeon that if you find an intracranial hemorrhage in the initial CT or sometimes as a complication, that the patient can be moved there for immediate management. Okay, faculty development is important. I'm talking about the interventional faculty. So we have 2 trained people, 2 more interventionists are being trained in-house cases as well as rotation, on a rotation basis outside THI Heart Institute, wherever there are being stroke cases being done, and we plan to train 2 more people. We have networking with nearby hospitals, especially in the 10-kilometer radius, that if they have an emergency arrival of a stroke patient, to rapidly transfer the patient to our institution. And we have awareness campaigns like these flyers. They are all over the place. We have placed them in the hospital. We have put them on social media. There are flyers around in the immediate vicinity of the hospital as well. I'm sorry, but the time is running out. We have a few drawbacks, mainly late arrivals. It's an impression because it's a THI Heart Institute, so it's a cardiac hospital, so probably they're not treating acute patients, so that's the impression. And the biggest drawback is the cost. Obviously, it's a private institution. The family has to pay, and they might not get the result that they are expecting, that what they have in mind. So that's about the stroke program. I'll just go through the history very quickly. And the case, we had a 72-year-old gentleman who had a prior MI and an EF of 40% and presented with a 4-hour history of left-sided weakness, slurred speech, and alternating level of consciousness. NIHSS was 16. We won't go through that. We had a dense MCA sign, effacement of right internal capsule, some pressure effect in the lateral ventricle. It was 4 hours plus, so we just got a CT angio, and we saw the occlusion at origin of the M1. This is the equipment we use for the headhunter as a diagnostic catheter, and an MPA1 guide, and Scion wire, rebar, Sophia Plus, and the solitaire was used as the stent retriever. So you can see here the occlusion, the M1, the ACA is visible. This is the stent retriever. This is the distal injection you'll see to check the placement. This is how it works. You deploy it, let it be there for 2-3 minutes. It traps the clot, and then pull the whole assembly out. We're not going to go into the technical details right now. We went, this was after the first pass, so you can see some flow coming up, inferior branch is filling up. We had to do 2 more runs after this. And improvement in flow, but still the superior branch was still occluded. We went again, couple of more runs. And I think acceptable result, TK3 flow. The patient had a slight deterioration in the conscious level after 24 hours, repeat CT. Well, it's performed anyways because you know, as we know that there are hemorrhagic complications. So you can see the just hemorrhagic complication and more pressure effect. Obviously, the neurologist is on board from the start, so there was some improvement in conscious level after mannitol infusions. But after 3 months follow-up, this patient was seen, no significant neurological improvement was seen.